Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
I'm Susan Kaufman, in for Attitude Magazine, and our guest today, Dr. Stephen Hinshaw, a professor of psychology at the University of California at Berkeley, will be talking about ADHD and gender. His work focuses on the developmental psychology of women and children, especially interventions for children with ADHD, girls and women. He's the author of more than 9 books, including a soon-to-be-released The ADHD Explosion and Today's Press for Performance. So, Dr. Hinshaw, thank you again for joining us.
Well, it's great to be here, and in the course of a few short minutes, we'll ask and quickly answer the question, does ADHD exist in females? Because for a long time, the field didn't really think that was true, and it's absolutely true. We'll mention this thing called the gender paradox. We'll talk about whether boys really have more ADHD than girls, and if that changes over time. We'll talk about some of the very serious clinical consequences of ADHD in girls as girls turn into teens and adults. And we'll mention very briefly this important concept of stigma, and it might be particularly important for girls and women with ADHD. We thought as a field for a long time 2 things. ADHD occurs in boys and not in men, so it's a childhood male disorder. We know that ADHD is a pretty equal opportunity condition across all socioeconomic strata, across both sexes, and ADHD does not stop once you hit puberty or age 21 or 25 on up the scale, although its form may change. The most flagrantly hyperactive kids may turn into mentally hyperactive adults with minds racing, but some of the physical manifestations may shift with time. There's a theoretical model, just to talk a little bit of science for a minute, called the gender paradox. If a condition exists a lot more in one sex than in another, like eating disorders, which occur about 9 times as frequently in girls and women as in boys and men, then the sex that it affects the least, prevalence-wise, like boys and men, must have a more severe form, probably have a higher genetic loading, and or more early in development risk factors. So we'll flip that now to ADHD, which does occur more in boys than girls, and we'll talk about that in a minute. So when it occurs in girls, the theory says, girls are going to have a more severe form of ADHD, probably more genetic risk, maybe more early in utero or early childhood neurodevelopmental risk. We simply don't know if that's true or not, but it's an interesting hypothesis. The same is thought about autism, which is about 5 to 1 boy to girl before the teenage years. So girls may have, on average, a more severe form of autism than boys. And are there really more boys than girls with ADHD? And the answer is yes, it's true. Some will tell you that if we just change the symptom list and talked about verbal behaviors, not just physical activity behaviors, then girls and boys would really be equal. Now, there's a parallel argument made in the adult years for depression. We know that in just about every culture studied, women have depression more than men at a rate of about 2 to 1 or higher. But some people say, yeah, but you see, guys, men exhibit depression through drinking or drugs or through aggression, and if you took that into account, there's really equal rates of depression. My thought is that if you take that too far, then maybe you're not talking about depression anymore. Everything might be equal to everything if you just stretch the symptom criteria enough. So I believe 2 things. First, we do have to take into account that girls are different from boys, and that we have to include symptoms of ADHD in girls that are more girl-like. But second, even if we do, just like autism, just like Tourette's, just like serious aggressive conduct disorder, boys in the first 10 years of life are the more vulnerable sex. Boys have more of these problems than girls. During the second 10 years of life, starting in the early teen years, the tables turn, and now girls come online for anxiety, depression, eating problems, self-destructive behaviors, and that's a very risky time period for teenage girls. Back to ADHD, The really intriguing thing is that recent studies have shown that by the time one is in adulthood, it does get closer to 50-50. Either women are more willing to admit attention problems than men, or because girls are more likely than boys to have had the so-called inattentive form, ADD without hyperactivity in the olden days, than our boys, those inattention symptoms tend to last more over time than do the hyperactive symptoms. So even though boys outnumber girls, by the time we get into adulthood, it's getting closer to 50-50. So ADHD in women is a big concern. So we have been doing here at Berkeley a study we affectionately call the BGAL study, the Berkeley Girls with ADHD Longitudinal Study. To our knowledge, this is the largest sample of girls with ADHD. When we first diagnosed them, they were under 12 years of age in existence, and we learned a lot about these girls. They went through our intensive summer camp programs, and we got all sorts of information about families and peers and neuropsychology, and we also have had a series of grants to follow them up 5 years later, 10 years later, because of our hardworking staff and because of the magic of social media like Facebook. We've been able, at our last follow-up, to get 95% of the sample in for assessments 10 years later. So their average age is about 20 as opposed to just under 10 when we first saw them. First, at the baseline, at 5 years, at 10 years, the girls with ADHD compared to our contrast group, our control group, had lots more problems academically, socially, in almost every domain. By adulthood, we were somewhat surprised to see that our girls, now young women, didn't have as many substance abuse problems as do most boys with ADHD at that age when they turn into young men. And some of the eating disorder symptoms we saw in the mid-teen years tended to be persistent in the girls, now young women with ADHD, but our comparison group of normally functioning young women had essentially caught up. There's lots of binge eating in general in the culture. What really shocked us was that if we go now, this is average age of 20, if we go to some very difficult outcomes, like have you ever made a serious suicide attempt? Not have you thought about it, have you made an attempt? Nearly a quarter of the girls who started off with a combined type of ADHD when they were girls, so they had a lot of hyperactivity and impulsivity as well as inattention. Much higher rates in those girls as they grew up than in the inattentive type or over in the gray, our normal comparison girls. And the second variable, related but different, are you engaging in cutting, self-mutilation, burning yourself, the awful ways that young people can engage in self-injurious behavior? Over 50% of the girls with this initial presentation of the combined type of ADHD were actively engaging in at least moderate or even severe self-injury, compared to about a quarter of the inattentive and about 20% of our comparison group. So ADHD in girls, especially when it's accompanied by pretty severe impulse control problems, tends to not only persist over time, even though some of those hyperactive symptoms go away, but for girls, there's a tendency to translate or transform this into pretty serious risk for self-injury. What is going on here is the question. So these girls had ADHD when they were young, and then over on the right, 10 years later, they're involved in pretty serious self-injurious behavior and a very cognitive measure of response inhibition. And the amount of delinquent externalizing behaviors when they were teens seemed to be part of that pathway. So girls with impulsive style ADHD may detour into acting out, but then start to act out against themselves when they get older. We have the same pathway, ADHD when you're a girl. Now the outcome is suicide attempts when you're a young adult, and it's the anxious and depressed symptoms as a teen that seem to kind of carry the ball and provide that link. What is stigma? Stigma is a Greek term. Most psychological and psychiatric terms are Greek. Stigma literally meant, back in the days of ancient Athens, a mark or brand of shame. How would you know in the agora, the marketplace in Athens, who was a slave or traitor? There had been a brand burned or tattooed into your skin so everyone could recognize under the toga. Most stigmas today aren't literal brands, they're psychological. You've got a skin color that's different. You're in a different cultural group. Used to be left-handedness was a stigma. Today, homelessness, substance abuse, and forms of mental illness are the most stigmatized conditions in our society. We in this country know a lot more about mental illness than in the 50s and 60s. Literacy has risen, high school psychology courses, media. But at the same time, you'd expect that we're more accepting. Stigma has actually increased over that time period against most forms of mental illness, even as we know more. Final point, you'd think that stigma pertains to schizophrenia, bipolar disorder, the very serious conditions that might land you in a mental hospital, those that are still open. Somewhat milder conditions like ADHD, the symptoms wax and wane, you'd think that stigma wouldn't be very strong. However, because of the very nature of ADHD, where a kid pulls it together in math but not in English, and people look like they're functioning pretty well, and then lapse into impulsive behavior, stigma might actually be quite strong because the perception is, well, you pulled it together 5 minutes ago, what's the matter with you now? You must have a weak character. You must have been raised wrong. So we can't make the mistake of thinking that stigma pertains only to psychotic forms of mental illness. ADHD is still stigmatized, and especially if you exhibit gender atypical patterns. If you're a gal, a girl, a teen, a woman, and you're engaging in behaviors that are more male stereotypic, you're impulsive, it's decided that you're rude, you don't control your impulses, stigma may be very strong. So that's our 13-minute introduction, and I'm willing and eager to take questions that the audience may have.
Thank you so much, Dr. Hinshaw. That I had no idea about the study, the longitudinal study that you are conducting, and it's completely fascinating and somewhat terrifying at the same time. To see those results about the behavior of girls who have combined ADHD. Maybe as a way to get started, because there are some questions about this issue, you could clarify for our listeners the types of ADHD. What do we mean when we say combined, inattentive, and hyperactive, and how those tend to vary by gender, so that we can sort of agree on the baseline here as we just go forward with the discussion.
Right, and this has just changed a couple of months ago, back in May, with DSM-5. With DSM-4, the idea was we have this condition called ADHD, Attention Deficit Hyperactivity Disorder. But there's three main types or forms. One's the purely inattentive form, the old, back in DSM-3, ADD without hyperactivity. You're kind of spacey, you kind of float through the day, you don't pay much attention, but you're certainly not very impulsive or overly active. So that's the inattentive type. You could have a more purely hyperactive and impulsive type. You're not necessarily inattentive, but you can't sit still and you blurt out answers. This is what often preschoolers might get diagnosed with. And then the most common type that comes to attention of clinics is what's called the combined type. You've got a combination of this inattentive set of symptoms and the hyperactive and impulsive set of symptoms. Now, what happens is, through our team studies and many others, these types aren't sort of pure types that stay in existence throughout development. Some people pick up more inattentive symptoms as school gets harder, in middle school and high school. Many people who start out as very hyperactive aren't as active when they're 18 as they were when they were 8. So these types tend to change. So what DSM-5 has recently said is, well, they're important to know which symptoms predominate. We'll call them how you currently present, your current presentation. Are you predominantly inattentive, predominantly hyperactive and impulsive, or do you have the combination? Because, again, these types may not be pure forms through time. But what our study that we just talked about a few minutes ago on the slide shows is that being very impulsive when you are young, especially if you're a girl, portends some difficult times later on. Finally, compared to boys, girls are more likely to have the purely inattentive form of ADHD. boys, it goes along with being a male, that you're kind of rude and you're loud and you're impulsive, etc. So that may be one of the answers to this mystery of why ADHD tends to stick around longer in women than in men, because girls have tended to have this more inattentive form, and those inattention symptoms tend to persist longer in time than the fidgeting and running around, etc. So that's a couple of minutes on this important question about types.
That's really interesting and helpful. A couple of comments that have come in. I think everyone's very taken with the results of your research, and one person specifically says, wow, now I understand why my daughters have the cutting and suicide thoughts. As a parent, what can I do to help?
Well, this is one of your worst fears as a parent. How long's this been going on? She's wearing those long sleeve sweatshirts, and then one day she pulled it up and there's cut marks on the arm, and why can't she talk about it? And the families panic. And so let's kind of take it a step at a time. There's a lot of pain in the world. There's a lot of pain being a teenager these days, and there's a lot of particular pain being a girl teenager these days. It's really hard with puberty happening ever earlier and society demanding that we stay focused and in school, past high school, past college, past graduate school, past post-grad. It's a long time before we reach financial independence. What's the recent fact I read, not about ADHD, but in the general population, over 70% of college students, college graduates in the last few years have returned to their family home to live because of the economic downturn. It's hard out there. If you're a girl especially, social media ringing in your ears, expectations to be perfect. I wrote a book called The Triple Bind a few years ago about this. It's hard to know whom to go to, because if you're not really perfect all the time, maybe you failed. Let's now pair this with, if you were a girl with ADHD, and especially if you tended to be impulsive, blurt out answers, blow out the candles at the birthday party, but it wasn't your birthday. Girls do not like this. Girls are very into social groups, as we all know. So the difficulty of being a teen, the difficulty of being a teen with ADHD, where you tend to get excluded from your peer group, can produce tremendous internal pain, and most girls don't have a way of expressing that. This terrible behavior pattern, the formal term NSSI, non-suicidal self-injurious behavior. Cutting, self-mutilation, there's all sorts of names for it. We tend to think in the clinical sciences it's a cry for help. It's an expression of a deep pain that the young woman can't express otherwise. But if you feel that blood oozing and feel the little physical pain, it's a way of expressing it. What we have to do is turn that around and talk about it as a family, through a school counselor, through a family therapist or an individual therapist. Once there can be recognition that there are words about this, that a lot of kids feel this, although your pain is unique, sometimes if it's severe, medications, beyond ADHD medications, other forms of medications are helpful. Often the whole family needs to be in treatment. We can turn these patterns around, but what's very striking and tragic about our longitudinal data is that girls with ADHD seem to be at 3 to 4 times higher risk for this way of expressing pain than the normal, if you will, typical girl going through the teenage years, because ADHD's impulsivity and social difficulties make it really hard to find other ways of expressing this pain.
Dr. Hinshaw, does your study give us any information on whether medication helps alleviate some of this tendency towards self-injury?
So this is a very important question, and our longitudinal study was really not designed to answer that, because we saw these girls when they were young, and they attended our summer programs, and we follow them in their teen years and follow them into young adulthood. And of course we track who's getting family therapy, who's getting school counseling, who's getting medication. But we're not in charge of the treatment. It's not a clinical trial. The problem is, anytime you do what this is called a naturalistic study, you look and observe and see who gets treatment and who doesn't. Who gets treatment? Usually people who have the worst problems get the most medication and the most forms of treatment. So going outside of ADHD for a moment into the realm of cancer, if you do a naturalistic study, what do you find? That chemotherapy and radiation are associated with worse forms of cancer and with early mortality and death. Why? Because people with the most severe forms of cancer tend to get these treatments. So you'd mistakenly think that these treatments aren't effective. You have to do an experiment. You have to randomly assign and see, make sure that half the people get the treatment and half don't on a random basis. When you do that in cancer, you see that chemotherapy and radiation can be life-saving. We know that's true for medications with ADHD if you do a random assignment study. So in our study, we track and we see that a number of girls stay on medication through adolescence. They're probably the ones who have the worst symptoms. Or, of course, maybe they're the ones whose families have the best health insurance. It's hard to know which is which.
Right.
We saw in our data some tendency for girls who stayed on medication, ADHD medications longer, had somewhat reduced risk for the self-injurious behavior. But it's hard to prove that because we didn't randomly assign these young women into treatment. So we have suggestive evidence that staying with treatment might help.
Okay, that makes sense. Yeah, given that your study started when these girls were preschoolers, so yeah. People would love to hear more about the specific risks to women of the inattentive form of ADHD. Specific question from a couple of young people in their 20s. What does this mean for me at this stage in my life?
So the inattentive form of ADHD, just to review for a minute, you've got more of inattention, disorganization, maybe sometimes it's called spaciness. You don't seem to follow directions very well. Maybe your working memory isn't so good. Hard to really organize a day, but you don't have as many severely impulsive or hyperactive symptoms. But the inattention symptoms, let's just talk about them. What do you need to do today to get into the best colleges and universities? Have ridiculous grade point averages. Things that I would have never gotten into college with my grades in high school. I did well.
Yeah.
So the pressures are increasing rapidly. Multitasking, extracurriculars, even when we're talking about elite colleges, just to maintain America's place in the job market. So many jobs are getting outsourced. Whether you're an accountant, whether you're a whatever job category, you've got to hold it together. And if you don't plan and organize, follow directions, and remember what your tasks are for a day, you end up in a pretty thick soup of floundering. And this is what the inattentive form of ADHD can really cause and predict. But for just about every other outcome, how are your math scores when you're 20, 21? How about, do you need special education when you were in grade school or middle school or high school? How about friendships you wish you had but didn't? The girls who started out in the inattentive type had just as high a risk for these problems as the girls who started out with the more hyperactive, impulsive, or combined type of ADHD. So the inattention symptoms don't predict specifically to the self-injurious behavior or suicide, but they predict to a lot of other, just about every other difficult outcome a young woman with ADHD might have. So getting organized, getting focused, medications can certainly help, organizational skills training, cognitive behavior therapy. This is a really important target for intervention too.
Just to wrap up this issue of the sort of people in their 20s, there are just two very specific and poignant questions here. One from someone who says, I'm 26 with combined type, and I hope it gets easier. But I'm afraid to have kids because it's hard enough to take care of myself and juggle a job and personal life.
Yeah.
So is there any sense that symptoms change over time for women as hyperactivity seems to get better for men and boys and men?
So our own study, we just got a big new grant to study our sample out to a 15-year follow-up, right to the age of 26, 27, 28. And there are a couple of other longitudinal studies of girls and women. So just to go quickly, number one, we know for men what happens over time. We don't know as much for women because we didn't think ADHD existed, and we haven't done these long-term studies nearly long enough. Number two, though, from what we have found and others have found, a lot of the most salient hyperactive and impulsive symptoms tend to decrease naturally with time. Number three, that does not mean, however, that everything is hunky-dory. The underlying inattention, organization and planning for a day still need work. The good news is that medications can help way beyond childhood, and that cognitive behavioral therapy, organizational skills therapy, to have some specific strategies for remembering a list, organizing your household and life, taking out some of the stress, taking away some of the stresses, couples therapy to help with relationships, as long as the therapist knows that ADHD is part of the mix. These treatments can work. I think the biggest problem, speaking to this particular question and more generally, is, boy, I've got ADHD. My life is kind of catapulting from one crisis to another. Could I ever have kids? I can't get it together. And all of a sudden, just I'm listening to myself talk, there's nowhere to start because I'm overwhelmed by everything. Rome wasn't built in a day. Anytime you're dealing as a clinician with a stressed family or a stressed individual, problems sort of tend to multiply. Pick one area, focus on it, build some skills and strengths. You start to see improvements, then build it to another area. I think one of the big problems in turning one's life around, and especially if ADHD is part of the mix, is you're kind of constantly bombarded by this melange of how everything isn't going well, and you're slowly drowning. Pick one target skill, pick one area to improve. Other things are not going to improve overnight. Work on that skill. You start to see improvement. You start to get in a virtuous cycle, and then you can apply the same principles to other aspects of your life, and you start to see improvement. And you don't get sort of drowned in, I'm just spiraling downward, nothing will ever improve. You've got to take, it's like doing sort of behavioral skills training with a young kid with ADHD. Start where you are, build from 5 minutes of time at the reading circle to 10 minutes, then to 15 minutes, and get on a positive loop.
I think that's a great suggestion. I just want to throw in here that we did a series of articles a few years ago, and you can find them on our website under Adult ADHD Life Stories, and they were profiles of women, several of them in their 20s, who worked with a coach and with organizers and made significant changes in their work and personal lives. And they were very inspirational. So I recommend going on to attitudemag.com and looking for those life stories. They in most cases, the girls explained, the young women explained with the coach, they alternated voices exactly what steps they took. And as you said, Dr. Hinshaw, in many cases it amounted to very small steps that added up to a significant change. So there's definitely evidence out there of women really making major strides in terms of increasing their ability to manage what's on their plates. Just switching for a moment, a couple of questions about depression and anxiety. Matthew says, why do therapists tend to accept diagnoses of depression and anxiety more often than they do for ADHD? It seems like there's often pushback by parents, by doctors, about the notion that the symptoms that they're seeing in girls may be ADHD and not depression and anxiety, and that's one part. The second part is sort of counter to that, is there in fact increased anxiety among girls with ADHD?
Yeah, these are two important linked questions. So taking the first part pretty quickly here, there's a lot of clinicians out there who were trained back in the olden days, may not have gotten enough continuing education. And remember, for a long time, a girl comes to the clinic and schoolwork isn't going well, friendships aren't going well. Well, girls don't get ADHD, so it's got to be because she's anxious, it's got to be because she's depressed, or maybe she's got a conduct disorder. Sort of ADHD is the last place you'd settle because girls didn't get that. There's still too much of that thinking out there. And we have to take the hypothesis well in hand that ADHD could be the culprit. But then the second part is you have to flip that around. Rarely does ADHD exist by itself. There's a few kids I've worked with clinically and in our research groups who've had kind of pure ADHD, no learning problems, no depression, anxiety problems, no oppositional problems, and you give a little bit of treatment, a little bit of behavioral coaching, a little bit of medication, things kind of turn around day and night, night and day. But most of the time in the real world, ADHD coexists with serious learning problems or with aggressive conduct problems, or especially for girls and women with significant depression and anxiety. So it's a chicken and egg. Did the anxiety exist first and the ADHD emanate from that? Or was there early ADHD, if you go back far enough and get the records out, and then over time, because of school failure and social issues, did anxiety and depression kind of emerge out of that, kind of a demoralization? Or did they both sort of start at the same time and are growing on a parallel track? All of those possibilities are possible. What the clinician has to do is say, let's do a very thorough assessment for ADHD. Let's do a very thorough assessment for what comorbid, coexisting conditions are going on. Sometimes ADHD treatments will help to get rid of or nip in the bud those comorbidities, but sometimes very serious anxiety is going to need a different set of treatments from the treatments that work for ADHD. Assessment, assessment, assessment. We have to be careful in diagnosing. We have to not do this in a very brief visit in a pediatrician's or general practitioner's office, so we know what's ADHD and how can we deal with it, and what additional symptoms and problems are going to require additional treatments. So that's my little mini lecture on that. I think most of the problems in the ADHD world would help be resolved if we really took the time to assess carefully what's going on.
And just to clarify, Dr. Hinshaw, I mean, we see oftentimes people who have been told that if they're being treated for ADHD, they can't not also be treated for anxiety and or depression. That's clearly not the case from what you're saying.
It's simply not the case. That's mythical thinking. That's old school thinking. That's right.
Okay. And question from Terry, what is the prevalence of learning disabilities and or anxiety, depression with ADHD, more or less? I mean, I think I've heard something in the 40 to 50% range.
Yeah. It all depends on how you define learning disability. If you take the broadest definition of all, do people with ADHD, kids or teens, have problems in achievement? Are they achieving less than they should? The answer is probably 80 to 90%, because if you're not paying attention, you're not focused, you're not organized, you're not learning up to your potential. But that's the highest estimate possible. If you take a more narrow approach and say, well, we're going to define a learning disability, a math disability, a reading disability, as a specific set of processes that limit your abilities mathematically or verbally, forgetting ADHD for a moment. Sometimes that's going to be a discrepancy from your IQ. Other people say you don't need to actually give an IQ test. You just look at the reading processes or math processes. The best estimate is about 1 in 4. About a quarter of people with ADHD have a coexisting learning disorder, learning disability. But again, many more than 25%, up to 80, 90% of people with ADHD probably aren't achieving up to their potential, not because of the specific learning disability, but because the ADHD symptoms get in the way of organizing, focusing, doing homework, etc. So that's why you hear such a big range out there.
That's interesting, yeah. Turning to some questions from women in their 30s and 40s. A number of them say they've only recently been diagnosed. In many cases, one person writes that she had no problems managing her life until she had children that were not easy to organize. And now, is having a great deal of difficulty managing the household. Another 35-year-old woman who says that she has had no problems with certain organization tasks. She pays her bills on time and so forth, but she's incapable of putting papers in order. So, what suggestions do you have for women in their 30s and then 40s who were just diagnosed and just trying to grapple with a diagnosis that they were unaware of earlier in their lives when they seem to manage fairly well.
This question raises a whole bunch of points, and so I'll just make a couple. Sometimes a kid, go back into childhood, well, it's doing pretty well, and then all of a sudden this thing called middle school occurs.
Mm-hmm.
You got 6 periods a day, 6 different teachers by 8th grade, and you've got a locker, and you've got to, when you come in, you got to remember you've got a locker and where your backpack is. And the challenges of life as we get older put real stress on organization, executive function, attentional systems. So ADHD may be manageable at one phase of life, and then it rears its head when the demands get harder. So, like the first question that you just mentioned, doing pretty well, and now I've got kids to organize, and school lunches, and PTA, and different schedules, and my own work, and my partner's work, and this is a real challenge. Second, you're in your 30s, your 40s, and we know that the age varies considerably, but hormone changes occur. Perimenopause occurs. And then as you get a little bit older, on average, the actual change in the menopause. And we know that, even independent of ADHD, the hormone changes women go through at that time of life are cognitive disorganizers. And there's word-finding problems. And a lot of women say, who've never had ADHD and probably never will, I felt like I had it during that phase of my life. And then if you've had ADHD, whether detected early or later, it's pouring a little bit of gasoline on the fire. So long story short, there's a big combination of the stresses of that phase of life, the multiple tasks that women still have to do more than men, and the beginnings of some subtle and then not so subtle hormone changes that can make this a really challenging time of life for a woman. A professional who understands support groups, finding ways to organize. Organizational skills training is not just for kids, it can be for adults too. There's really ways to get at this, but again, recognition is a big part of it.
Interesting. A very fascinating question here from someone who says that she has always been hyperactive and used it absolutely advantageously, both professionally and academically. But now, I guess I'm intuiting here that she's in nearly 40. She says for the first time, her inattention is really affecting her family life. And she's considering medication for the first time at age 40. Is there anything that she should know about medication for women in 40 and up? Is there any difference or any special thing to look for or avoid? Is medication just as easily used by middle-aged and up women as younger women?
The short answer is yes, if the clinician is aware that dosages might need to be somewhat higher in adults than in a kid.
Okay.
That. Number 2, the first medication that's tried may not work. And a lot of clinicians say, oh, stimulants don't work for my patient here, and we'll give up. Back in childhood, we had a lot more data, and adolescence, there's no guarantee that the first particular pill that's tried will work. Might take a second or third, and you have to really do experimentation with dosage. 2 people with ADHD, same age, same weight, almost identical twins, they might vary in their dosage 6 or 8 times. If we could predict that, if we could do a blood test and do a genetic screen and say, you need this low dosage, no, but you need that high dosage. If you find the answer to that, anybody in the audience, call me. We'll make a big profit very soon. That would be a growth industry. But we can't predict that now. The only way to do it is a kind of informed trial and error. Many more people can respond to medications than are at first thought if the doctor is systematic and if you have the person you're working with not give up. So are there contraindications? It depends on the medical history. The doctor's got to do a thorough assessment. So there's no evidence, though, that, oh, well, you haven't tried medicine before, so age 40 is too late. Might work great, but you've got to be patient. Let me make one other comment about this, which is, how do we know that it's ADHD? How do you make a diagnosis? Because this question, I think, implied that, I was pretty on the go, pretty peppy, high activity rate through my life is probably pretty adaptive. All of us know people who are about a 78 record rather than a 33 if you go to old vinyl, and they do pretty fine. They start 50 projects a week, and maybe they complete 10, which is better than my starting with 5 and completing 2. Activity level alone is not the issue. It's whether it causes impairment. Are you moving so fast that you can't focus? And as your situation changes in life, whether it's kids or a new job or a new set of expectations, sometimes the impairments take over. So it's possible to have a very high activity rate and thrive in it. And it's also possible to have that high activity level and be very unfocused and somewhat impulsive, and we make a diagnosis because it's just not working for you.
Interesting. Yeah. Just before we leave the job issue, this just seems to be, I think this speaks to your increasing demands of modern life. Cheryl writes that she finds it increasingly difficult to keep up with the pace of her work environment. By the end of the day, she's mentally exhausted, just completely without energy to do anything. She's 49. And she thought originally this was just her age, but now she's wondering if this is an ADHD symptom, or could it be she takes Concerta in the morning? Is it wearing off? What do you think about a 49-year-old with a demanding job who finds herself just wiped out at the end of the day? I guess it could be any of the above, right?
Yeah, I mean, the caller here has 3 or 4 really good hypotheses, each of which could be true. And this is, of course, impossible to make an on-the-spot diagnosis on a webinar, and what the clinician has to do is talk, get the history, be a bit of a single-case scientific experiment. Well, maybe if it's a medication, maybe we need a second dose of a different stimulant later in the day because it's not lasting the full 12 hours the way maybe it's supposed to. Or maybe there's hormonal changes related to perimenopause that are now trumping whatever ADHD symptoms there are, and it's time to ask for flex time at work. Or maybe you'd have to be systematic and try each hypothesis. This is what a good clinical relationship is. I can't tell from this very astute question which of the possibilities it is, but I think I bet the right data would figure out which of the answers is the right track to go down.
Right. You know, one of the things that, when always in writing about medications, as we do frequently at Attitude, we come back to this question of how important it is to work closely with a clinician to try different medications, different dosages, to track your symptoms, to meet frequently. And yet our readers seem to have tremendous difficulty finding a clinician who will work with them at that level. There seems to be sort of here's the prescription, good luck, and what do you have any suggestions? I think is it better to find a psychologist who has a partnership with a psychiatrist who writes subscriptions who might have more time? There's clearly a shortage of psychopharmacologists out there.
Well, there's a shortage of real ADHD experts for kids, adolescents, or especially adults, number one. Second, there's a shortage of time that most insurance will reimburse for a medication visit. A few minutes usually isn't enough to really not only get support, but to answer these questions and test hypotheses. And third, if I were czar, no one's appointed me yet. I'm kind of waiting by the phone. But if somebody will appoint me for a day or two, I would say, why aren't we doing more team-based treatment? Back in
it seems like that would be the logical answer, right? I mean,
why don't we have health clinics in the schools so the observers and the teachers and the aides and the psychologists and the prescribing doctors are all getting the same data? The same is true in high school. The same is true for adults. Team approaches, educational people, vocational people, social work people, psychological people, psychiatric people. If you're communicating and communicating with the client at hand, you're going to have not only a team approach, but a multifaceted approach to get at ADHD takes its toll on a lot of different aspects of life. And if we don't get the right information and try different strategies for those different life aspects, any one may fall short. So appoint me czar, and we'll mandate team-based approaches around the country in the next 3 weeks.
I think that makes sense because clearly, the pressures on doctors of managed care, 5 minutes, 15 minutes an appointment, they just doesn't seem reasonable for them, for people to spend the amount of time that's needed to really get the medication right.
Because, again, the symptoms of ADHD transform and change form as life stresses, life situations, life challenges ebb and flow. It's usually not a constant thing over time unless you have a very, what's the right word, sort of one-track life that nothing much changes in. But kids, jobs, stresses, relationships, these are going to influence the course and severity of ADHD symptoms day to day.
Right, that makes sense. Just one last question on medication. There's someone, Allison, who's written in to say that she's been told by her practitioner that Strattera or non-stimulant medications, I guess without regard to brand, work best for girls with combined ADHD with anxiety. Does that make sense to you, or I guess she's gotten conflicting information between her pediatrician and her psychologist. Pediatrician says, in a non-stimulant, if there's anxiety involved, psychologist said more than one medication. I would guess there's no rule of thumb here, in keeping with your previous statement about each person being different.
We would like to have some general rules. The problem is all the ones we find in the ADHD world don't apply to everybody. So on the face of it, Strattera, trade name for atomoxetine, was initially tried as and marketed as an antidepressant medication, not really an anti-anxiety because it works on the norepinephrine system, not on the serotonin system. You're not going to get the dopamine boost you get with the stimulant. Sometimes that dopamine boost can unearth anxiety in people who are prone. So maybe out there in the world there's a slight tendency that the doctor who said in general the non-stimulant will be better for comorbid anxiety is right. However, we know from a lot of research that many kids with ADHD plus additional anxiety do pretty darn well on stimulants if the dosage is managed well, and especially if additional treatments are given. So individual differences probably trump any general rule about which medication class works for which particular symptoms.
Okay. And this person probably needs to take the trial and error approach to her clinicians and see if they'll give a trial of different combinations.
Probably so. And I'm just going to amend even the term I used a few minutes ago, trial and error. What this does not mean is, oh, gee, I better switch my dose every day. I'm not feeling quite right. That's not at all what it means. It means that, sometimes with a grade school kid, you go a week on dosage X, and a week on dosage Y, and you get the teacher to do ratings a couple of times a week each week, and the parents too. And after a few weeks, you gather information on the benefits and side effects. So it's a systematic single-case experiment rather than a trial and error, oh, gee, it's not quite working today, let me change it tomorrow, because then you've just got chaos and you don't know what's happening. So trial and error is let's put an asterisk on that term.
Okay, got it. Yeah. No, I think that's helpful to really give each medication a good try and track symptoms carefully and make an informed decision. Okay, therapists. A couple of therapists on the webinar who are asking, how can I empower my patients, clients who are girls and women with ADHD as a therapist? What can I do best to help the clients that I have and for whom ADHD is a significant issue?
Well, let me shoot from the hip here because, of course, the essence of any therapeutic relationship is a great alliance and really aligning with the goals that you and your client work out. So it's going to be highly individualized. But one thing that comes to mind is validation. ADHD is, if the diagnosis is accurate, part of the picture here, and that doesn't mean it's a horrible label that taints your life. It's empowering to know that these are some issues you're going to have. And there's some ways to fight them, rather than, oh, we don't really think it's ADHD, it must not be, girls don't have this, the kind of perennial ambivalence about whether this is even going on, I think would be confusing for a client. So if the diagnosis is accurate, that doesn't define the client, but it's an aspect of life that's going to require some specific strategies around those specific challenges. And I think if a therapist can be confident in his or her diagnostic acumen and can take this informed trial and error approach and be empowering for the strengths as well as weaknesses and impairments that the ADHD symptoms produce, I think that can lead to a virtuous cycle of an active approach to getting at the problems that still exist.
Okay. That makes sense. Crystal, listening to our webinar, says, hey, I have a hard enough time finding one doctor to take my ADHD symptoms seriously, much less a team. So, yeah, we're with you, Crystal. We know. A number of folks have asked questions about whether women who are being treated become more aggressive. One person says her husband says she's more verbally aggressive, and another person says her daughter is more defiant on medication.
Yeah, I mean, this would usually not be the case. Often, especially with boys, but with girls too, you get ADHD in the pre-adolescent years, and the teen years is linked with, comorbid with a lot of oppositional defiant behavior. So treatment can kind of calm down that tiger a bit. However, it's possible that a person who's been somewhat perplexed and not sure and now with the right treatment is asserting, we'll talk about women here, her rights to have it done right and finding a place for herself in the world, that assertion may come across to others as aggression. It's all part of the data and information that the family gathers and is presented to the clinician, and you make good decisions about whether this is transitory, whether this is a permanent trend, is this healthy assertion, or is it really over-the-top aggression, and then you adjust treatment accordingly.
Interesting. Yeah, someone else chimes in and says that she's not defiant on medication, but she's less shy and quiet and withdrawn than she used to be, so she may be more talkative.
That could be a good thing.
More assertive, which can be a good thing.
Might be perceived as aggressive, right?
Exactly, right, depending on, just might be more assertive. Unfortunately, I think we're running out of time. This has just been totally fascinating, but let me just throw one last one at you if I can. A number of people have asked about the best kinds of doctors for diagnosis, both for adults and children. One person says, for my child, is it best to go to a neurologist, a pediatric developmental physician, or a pediatric neurologist? What is the best? I think most children are diagnosed by their pediatrician, are they not?
That's still true. That's right. There's not enough specialists to go around. And so
is it best to find a specialist? Yeah.
My answer to this is it depends, regardless of neurological training or if it's a developmental behavioral pediatrician or if it's a child and adolescent psychiatrist. This is why CHAD exists. This is why support groups exist. In your area, talk to other families who've had experience with the good and not so good clinicians in the area. A person who knows the score about ADHD and schools and assertion and organization and jobs, that's going to trump the particular specialty all the time. However, back to 20 minutes ago, teamwork, if the person doesn't have the neurological background but is in a team practice or consults with a neurologist, if neurological issues come up, then you get double the benefit. So It's really based on reputation and experience, I believe, in dealing with the kinds of day-to-day problems that ADHD involves and invokes, more than the specialty training per se.
Okay, that makes sense. Dr. Hinshaw, is your study going to be published? I think there's a great deal of interest among all of us to see the results.
Yes. Our 10-year follow-up study, there's many sub-studies that will be published too, but the main findings were published last December 2012 in the Journal of Consulting and Clinical Psychology, Hinshaw et al., 2012, JCCP, Journal of Consulting and Clinical Psychology, and we're continuing to analyze data and publish additional findings about, because we know these girls when they were girls and when they're teens and young adults, what is the pathway and trajectory, not just how are they looking at age, 20 to 22, but how did they get there? So, and now with our new grant to follow up the sample as far as we can, as well as we can into the mid to late 20s, we think we're going to have even better data.
We thank you so much. We look forward to the publication of your book. Dr. Hinshaw has agreed to join us again toward the end of the year when his new book is out. And thanks so much.
Thank you for having me on.
Our pleasure.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.